week off. I still got it better than when I left. Probably I forgot more often than that. So, anyways, all right. So the heart. When we look at our ability as people working in physical therapy to help our patients improve, many times people get really focused on the specific impairment limitation that they're seeing, their shoulder problem, their back problem, the fact that they had a stroke and they can't move their left leg. Um, and really, all of our body systems' ability to function at maximal ability is dependent on the heart and this health of the blood vessels that are then delivering blood to those different tissues. So when we look at problems with orthopedic injuries, whether it's a soft tissue injury, strain, sprain, whether it's a fracture, whether it's recovering from an ACL surgery, a joint replacement surgery, if we can't deliver good blood flow to that area and we can't remove waste from that area, we're going to have a hard time healing that body part. And we see that a lot of times, especially when we start getting down to the foot, because as we get further and further away from the heart, the ability of the heart to generate sufficient force to drive blood all the way down there is harder. And then if we have the blood vessels getting scarred down, getting narrowed down more distally, then again, the ability to get good perfusion in those tissues starts to get impaired too. So almost every patient that we see can benefit from improving the health of their heart and their cardiovascular system. The vast majority of medical costs in this country are related to um, just the chronic long-term effects of problems with the big expenses in our healthcare system are cardiovascular disease, diabetes, um, and conditions like that, cancers. All of those things are helped immensely by regular aerobic exercise. And so it's a part of our field that certain settings you will emphasize on. And when we think about a patient that's had a heart attack or that has a bad case of congestive heart failure or had a heart transplant, it's obvious that we need to work on the health of their cardiovascular system. But really, virtually every patient that you work with would benefit from this. And a lot of therapy settings aren't set up to really give us good time to help emphasize improving that. But I think it's important that we always teach our patients and educate our patients of the need to get regular aerobic activity, whether that's just walking, riding a stationary bike, doing whatever people enjoy. The most important part about maintaining the health of the cardiovascular system is consistency, is making yourself work harder than a resting level on a very regular basis. And if we could convince society to do that, we would drastically reduce our healthcare costs, medication costs, disability related to um, the impairments and things that come up with poor circulation and poor cardiovascular system. And then the number of deaths would go down immensely, and we'd have much longer life expectancy too. So I'm a big advocate for pushing the cardiovascular system, having worked in inpatient care a lot, hospital care a lot. I've worked with a lot of patients that need that type of conditioning. Um, and I think there's a lot of settings, outpatient orthopedic settings in particular, that ignore the health of the cardiovascular system. And when we look at working with those patients, when you start looking through patients' charts, when you get out on your clinicals, pay attention to how many of them have cardiovascular related diseases, whether it's coronary heart disease, coronary artery disease, high blood pressure, atrial fibrillation, some other kind of weird arrhythmia. Um, all of those things put the patients at higher risk of something bad happening while we're working with them. We're asking them to exercise. We're asking them to work on getting their knee strength up. We have them jump on the bike. We have them do things for their back, for their shoulder, whatever. All of those things are making their heart work harder. And when they already have conditions and we don't really screen people for problems related to it, and we just go ahead and start exercising them without taking their blood pressure, without taking their heart rate, without asking them if they're feeling short of breath, we need to be monitoring and being aware of those signs. And it puts you at big liability risk if you know that this patient has a history of a cardiovascular condition and we don't check their vitals when they come in. Because if they come in and their heart rate's 98 and their blood pressure is 170 over 100, and we don't know it because we haven't checked it, and we throw them on the bike, or we have them start doing isometrics where they're going contracting really hard and jacking their blood pressure up, the risk of them having a heart attack, of having some other big event, goes up dramatically. And it's on us to check that. And for those of you that have experience working in outpatient clinics or are currently working in them, either think back to your time in those clinics or think about how you see patients treated there today. And if you're seeing an older population in particular in that clinic, and the therapists and PTAs are not checking vital signs on those patients, that's negligence. They really need to be. And so it's super important to just not take for granted that, oh, they walked in here, they're fine. You never know when cardiovascular events are going to happen. And if we're not paying attention to it and recognizing that, yeah, they have this diagnosis on their chart, oh, well, I'm not worried about it, I'm just seeing them for their knee, that's a short-sighted and not a whole body way to treat patients. And really, we need to be thinking about the whole person and trying to maximize wellness aspects, even though it's not generally very reimbursable the way that our healthcare system is set up. Our healthcare system is set up to treat problems. And if the problem isn't that they actively are recovering from a problem like a heart attack, then a lot of people say, well, I'm just going to worry about what we're supposed to worry about, the knee, the hip, the shoulder, or whatever. So I will re-emphasize this in pretty much every class that I teach. So you'll get tired of hearing me talk about that. So I'll get off my soapbox for now. We'll actually talk about the anatomy of the heart and the cardiovascular system. So average person, resting heart rate about 75 beats a minute. The more fit people become, the lower that tends to go. When we look at how much blood we need to pump at rest, we have what's called a resting cardiac output. And for the average sized person, that's generally going to be about 5 liters a minute. If you have a really strong heart and can pump a lot of blood with one beat, you have a big stroke volume. That's the term for how much blood gets pumped out with one beat. If we pump a lot of blood with one beat, then to pump 5 liters of blood per minute, that average volume, we don't need to beat as many times. And so that's why you see a lower heart rate typically with people that have a better functioning heart. Certainly body size is going to change the total cardiac output that we need, but when people become out of shape and their heart can only pump a little bit of blood with each beat, then they have to beat a lot faster. And when you have to beat a lot faster at rest, that means your ability to increase that heart rate even more to meet the challenges of increased activity goes down because you have less room to increase. If our general rule of thumb for max heart rate that we guess somebody would have is 220 minus your age. There's other ones, but that's the most common one that people know. So as we get older, our max heart rate goes down. And if our resting heart rate is that much closer to our max, then we can't really push ourselves that high. But if our max is here and our resting is way down below that, then we can have a lot of beats in reserve to pump a lot more blood and do a lot more work and be able to accomplish a lot more without feeling fatigued or work at a higher intensity without feeling fatigued. So it's hugely important that we, when we look at resting heart rate, that's what it's telling us. If somebody's resting heart rate is 95 or 100, that's a sign that they're not pumping very much blood with each beat, or they're hopped up on caffeine or something like that too. So a lot of medications and other substances can elevate your heart rate. Now, if your heart rate's too low and it's not that strong, then we have problems because then we can't really generate a big enough cardiac output. If I can only pump a little bit of blood and my heart is, for whatever reason, abnormally slow, then that creates issues. And that's what we see when we hear about people getting pacemakers put in. A lot of times it's because their heart's not capable of beating fast enough on its own, and it needs some extra help to do that, to help the body meet the demand. So hopefully you know from either prior background or just general knowledge that arteries are the big vessels that carry blood away from the heart. Veins are carrying them back to the heart. We'll talk specifically about the circulatory system tomorrow in lecture. From arteries, we go down to the next smallest size vessel is an arteriole, still carrying blood away from the heart. And then we go into the capillaries. And the capillaries are kind of this transitional vessel that are really kind of part of, it's like the tail end of the arterial system, but it's also the front end of the venous system. And so those capillary, what are called capillary beds, are just these network of really small blood vessels that get down into the tissue level to actually help the oxygen and carbon dioxide get exchanged, to help other things escape the bloodstream, pick up waste products. That's where really the work in the cells happen, is at that capillary level. Once the capillary veins kind of start picking things up, then we see similar terms to what we saw on the arterial side. It's going to go to a venule, and then a vein, and then back to the heart. So we'll spend some time looking at that in lab this week also, and get clear on that. The great vessels are the terms for the big vessels that are leaving and entering the heart. So when you hear about things like the aorta, the inferior and superior vena cava, the pulmonary artery and the pulmonary veins, those are the great vessels. Those are the ones that are either directly exiting the heart or directly entering the heart. And so they're bigger in diameter, because all the other, if we look at the arterial side, we've only got two ways out of the heart. One going for as far as pumping blood, one that goes straight to the lungs and then brings it back to the heart, and then the other one that pumps all the blood out to the body. So the aorta needs to be really, really big. And then as the blood flow gets dispersed through the body, then those branches become smaller and smaller and smaller. On the venous side, it's just the opposite. The itty bitty vessels are out distally. And then as the blood is returning to the heart, then the vessels get bigger and bigger, because it's essentially like a lot of small feeder roads merging into a big 8-lane highway or interstate. That big interstate can carry a lot more traffic because it's much wider. And that's kind of what we look at with the great vessels. They're just the bigger ones, so they can carry a lot bigger volume. Heart valves, you guys talked about valves, I'm guessing, last week in lab. What are the 4 valves that we have in the heart? Did Greg go over that? Hopefully.
Tricuspid.
Okay, so tricuspid, what's another name for the tricuspid valve?
The atrioventricular.
Okay, yep. And
Or
more,
the
go ahead.
right.
Right, yep. So the right AV valve or the tricuspid valve. And the easy way to keep that straight, and I don't know if Greg shared this, when we look at the heart and the lungs, the lungs, there are 3 lobes on the right lung. There's only 2 lobes on the left lung. The right AV valve is the tricuspid valve. It's got 3 cusps to it, just like the right lung has 3 lobes to it. When we look at the bicuspid valve or the mitral valve on the other side of the heart, then the left lung only has 2 lobes, and that one only has 2 cusps, or the bicuspid valve. So that's one way to kind of keep straight which it is, and that helps a lot of students kind of remember which one is tricuspid and which one is bicuspid. If you're not sure about tri or bicuspid, you're certainly always welcome to just say right AV valve or left AV valve, because that means the same thing, and that's really probably becoming the more common term that you'll hear. What's another name for the left AV valve besides bicuspid?
Mitral.
Mitral. So that one's got 3 different names. So it can be confusing to keep them all straight, but it does have 3 different names. What are the other valves that we have?
Pulmonary semilunar valve.
Okay, so yep, the pulmonary valve or pulmonic valve sometimes, or which is also the right semilunar valve, and then the opposite side.
The aortic semilunar valve.
Yep, the aortic or the left semilunar valve. So those are kind of the big ones that you need to know. And so we come in, blood's going to return to the right atria, go through that tricuspid valve to the right ventricle, go from the right ventricle and pump blood out the pulmonic valve to the lungs, comes back into the left atrium, and then goes through the bicuspid valve or mitral valve or left AV valve to the left ventricle, and then from the left ventricle out the aorta, the aortic valve. So in order to pump that blood effectively, we have to compress the chambers, and especially the ventricles. And when we're able to generate enough force in the ventricles, then we push that blood through the valves. And as long as the valves are working correctly, then it limits the amount of blood that can flow backwards to where it came from. Whichever chamber it was leaving, it comes right back into it. And that creates a lot of problems when that happens. So we need to have enough pressure to push that blood through the valves, send it on its way, or return it, into whichever chamber it needs to go to next to be pumped out. So there's our general kind of schematic of where blood is going to go. The blood is all, or the vessels are typically depicted as blue or red when we look at veins or arteries, and deoxygenated blood is less red than oxygenated blood. That's related to the hemoglobin molecule. And so that's typically why our veins do look a little bit more bluish in appearance. And it makes it easier to kind of keep straight. And images that are on your quiz related to the circulatory system, quiz 12, will be shaded blue or red to kind of help you identify whether they're looking at a vein or whether you're looking at an artery. Because on the surface, they can be hard to tell the difference between. So when we look at this schematic, we've got the blue coming in the right side, going out. We have one pulmonary artery that carries blood away to each lung, the right and the left lung. When we return, we have two pulmonary veins that are coming back. And these are the only vessels in the body where the colors don't match the names. The pulmonary artery carries deoxygenated blood, but it carries blood away from the heart. And that's the definition of an artery, is a vessel that's carrying blood away from the heart. So that's what we have going on here. And then why it's blue. Once that blood goes through the lungs and has had the chance to exchange gas at the alveoli, then it's picked up oxygen. So now the pulmonary veins that are returning to the right, or excuse me, to the left atria are red, even though they're veins. When we look at everything coming out the aorta side, the systemic circulation, then the red and blue coloration holds true. The arteries are always going to be red, the veins are always going to be blue, but that pulmonary circulation with those great vessels is backwards as far as the color goes, because of the deoxygenated blood being carried away from the heart and the freshly oxygenated blood being carried back to the heart. All right, so our heart is a little bit, it's not dead center in our chest. It is tilted and kind of skewed a little bit. It's both leans to the, so that more of the mass of the heart is on the left side of the chest wall, but it's also twisted a little bit. And so it's twisted so that when you look at the heart from the front, most of what is visible is all those right-sided chambers, the right atria and the right ventricle. The left side of the heart, the left atria and left ventricle, are more posterior because it is kind of twisted. So it's not split like if we look at the lungs, we got the right and the left lung, they're distinctly on the right side or on the left side. The heart, because it is rotated essentially, it's basically rotated and tilted. So it's a little bit wonky and out of place, but that's the way it fits. And that's partly why the left lung only has two lobes, because it has to accommodate the fact that there's more heart mass on that left side, and we don't have quite as much space in the left thoracic cavity. As far as how we name the heart, hopefully, I don't know if Greg talked about these, but the terms base and the apex, when you look at the heart, when we think about a pyramid, the base is always the bottom, the apex is the peak, and that's kind of what apex means, is the peak. With the heart, it's upside down. The peak is pointing down. The apex is still the pointy part, but it's the bottom of the heart. It's basically mostly where the left ventricle is on the bottom of the heart. And the base is actually the top. So the base of the heart is essentially where the pulmonary artery is coming out and where the aorta is coming out. So here's kind of some images showing it. You can kind of see the sternum right in the center. And we have a lot more mass poking out over here. The left ventricle is significantly bigger than the right ventricle. It has a much thicker wall. It has a lot more muscle mass to it. So it takes up a lot more space. It has to generate a lot higher force than the right atria or the right ventricle does. And so that's why it needs to be a lot bigger. We'll talk about that as we go. So these are nice images, kind of gives you some perspective of it, of how things are kind of oriented in the body. This particular CT image is kind of reversed. It's looking at it from the top, but if you look closely at the labeling, what's shown on the left side of this particular image is the right lung, and here's the left lung over here. So you can see that we've got less, this black space is essentially all lung. So the right lung is bigger than the left lung because more of that heart is intruding over into that left thoracic cavity space. All right, so our pericardium, we talked about this very early in the semester when we went over all those serous membranes. And so the pericardium, we do have the visceral layer that's directly adhered to the heart muscle. We have the parietal layer that, and then we have that serous fluid in between those two layers. And then that parietal layer has an additional outer covering, the fibrous pericardium, that gives it extra protection. So unlike like the abdominal viscera, we have an additional layer. And when we used to have our samples in our lab upstairs, before we closed down our cadaver lab, we had a number of hearts that had the pericardium dissected but still attached to the heart. And it was a very thick, that fibrous pericardium was very thick. It's very similar in texture and thickness to the dura mater. It is a really tough barrier, and that's what we want. We don't want anything to be able to puncture in and cause problems to the heart, just like we don't want anything to puncture in here. Now, the brain has, the more rigid skull that's kind of more continuous to help protect it, but the heart has the rib cage and the sternum right in front, the spine behind it. So we do get this kind of bony cage to give us some protection, but then we have this additional fibrous connective tissue that further gives us some protection too. So those are important components to the heart. And so this is a nice illustration to give you kind of some look at those different layers. We've got that fibrous pericardium, the parietal pericardium, and then the visceral pericardium that's right on tap, attached to the heart muscle itself. All right, our heart muscle itself, we've got 3 layers. And so like a lot of our body tissues, we use similar terminology for those layers. We have our epicardium, and whenever we see that epi term, that's almost always the most outermost layer. We have the myocardium itself, and that's the middlemost layer. That's essentially the contractile portion of the muscle tissue. And then we have the endothelium. So almost always when we see that prefix endo, that's referring to the most internal layer. And this endothelium, that's the actual part that's in contact with the blood. So the endothelium is going to be the surface that is inside of all those different chambers, the right atria, the left atria, left and right ventricles. So that's an important component there. So the thickness of the myocardium will vary tremendously between the atria and the ventricles. I wish I did still have at least one heart specimen. The atria are really, really thin. They're not much thicker than the fibrous pericardium. It is not a lot of muscle mass. And so when we talk about the EKG, which we'll talk at some point today, that's an electrical tracing of heart muscle contraction, their electrical activity. The amount of electrical activity that the atria generate is tiny compared to what the ventricles generate, because there's just not that much muscle in the atria. The ventricles are way thicker, and again, the left ventricle in particular is way thicker than the right ventricle too. So this thickness does vary quite a bit. All right, here's a great image, lots and lots of terms that you should be familiar with on here. I wouldn't say you need to know everything. There's a couple things that you don't need to know, but that's about it. I won't ask you anything about ligamentum arteriosum, but I think in looking at everything else on that list, you should be familiar with everything else on that list. So this is a great picture to get familiar with and to get an understanding of. So we're looking at this straight on view of the heart. If we took away the sternum, took away the center portions of the rib cage and everything else, this is kind of what it would look like. And so here's our right atria. Here's our right ventricle, basically below this, where these blood vessels are. Where this set of blood vessels is coming down here, that's the dividing line between the right ventricle and the left ventricle. So even though the left ventricle is way bigger than the right ventricle, when we look at it from the front, most of what you're seeing is this right ventricle right here. And you can see the right ventricle, and that muscle mass is attached really directly to this, what's called the pulmonary trunk. And that's kind of the first section of the pulmonary artery. So we have a short branch that's a trunk, and then it kind of tees. And then we're going to have a right and a left pulmonary artery that's going to branch off. And so that's what you see. We only see this left one. The right one is tucked underneath the arch of the aorta. And so that aorta, if you follow it around, and we can't really see where it comes from, but it's basically tied into that left ventricle right here and pumping its blood out that way. So that's kind of what we're looking at the front as far as those different chambers. You can see just a little bit of the left atria right here. And the loose kind of thin muscular wall of the atria are also called the auricle. So that term that we had for the outside of the ear, we had either the term pinna or auricle. That kind of means the same thing. It's kind of an ear shape. And so if you look at that shape, it's kind of like an ear. So somebody decided to give it that same name. And so that gives those atria have a great ability to accept a lot of blood because that tissue is really loose. And so when we're, if we're exercising at a high intensity and we're pumping a whole lot of blood, we need to let those atria accept a whole lot of blood so that the great veins can keep dumping their returning blood into it. And if we have that great capacity to kind of have this overflow tank, more or less, where that tissue is super loose. If muscle tissue is tighter, then it's harder you have more resistance to blood filling up that chamber. And so we do have problems sometimes in the ventricles where the heart muscle gets too thick and then it can't accept as much blood because just if you think about somebody that's quote unquote muscle bound, we often think of muscle bound people being limited in their flexibility. It's not really true, but it kind of makes sense in some ways. The more mass you have and muscle tissue has some tone to it, it takes more force to stretch it apart. And so when the heart muscle wall is very thick, it does limit, you have to have higher pressures pushing against those walls to make them accept more blood. And so it helps you generate more force to pump blood out, but it can make it harder to accept blood in, especially if the chamber size doesn't increase along with it. So the other things you want to be familiar with over here on the sides, we've got our great vessels returning blood to the right atria. We've got our inferior vena cava and our superior vena cava. So those both dump into the right atria. We'll look at an image on the back side of the heart and we'll talk about the other big source of returning used blood to the right atria. And then coming off of our aorta, you're going to want to know these big vessels here. So we've got our brachiocephalic trunk is what we call this, and brachio means arm, cephalic means head. So this vessel here, on this first of these three vessels coming off the top of that arch, is going to turn into and split to become the right subclavian artery, as well as the right common carotid artery. When we look at the middle vessel, that is our left common carotid artery, and then this is going to become our left subclavian artery right there. So on the right side, this one vessel is going to split and basically become the same thing as these two vessels that are shown here. They're, excuse me, coming off the left side. The other things to look at down below, we've got the descending aorta. And so you can't see it, but the rest, after we pass the arch of the aorta, it just goes straight down. And it's going to change names as it goes through, whether it's above the diaphragm or below the diaphragm. It changes names there, but as a whole, it's the descending aorta. On the surface of the external heart wall, we've got our coronary sulcus. And the coronary sulcus basically goes around horizontally. And so that's the division, the indentation in the heart muscle that separates the atria from the ventricle. And then on running a little bit more vertically, we have this interventricular sulcus. And we have an anterior one that we can view from here. And then it's going to wrap around the backside and be the posterior one. And that's essentially the dividing line between the right and left ventricles. So the sulcus divides top and bottom. The interventricular arteries and sulcus there divides left and right, at least at the ventricular level. So I think that's kind of the big stuff to know there. We'll talk about these specific blood vessels names in a bit. Oops, I jumped too far. All right, so here's the back of the heart. And so almost everything that we're looking at here is left side of the heart. All of this mass over here is the left ventricle. We do see a little bit of the right ventricle, visible. we see a little bit of the right atrium, and we see the backside of the left atrium. On the backside of the left atrium, that's where we see those pulmonary veins returning that freshly oxygenated blood back to the left side of the heart. So we've got 2 coming from the left lung. We've got 2 coming from the right lung. I believe these are probably just superior pulmonary vein and inferior pulmonary veins based on the orientation. But that is where we're going to dump all that fresh blood back into the left side of the heart so it can get pumped out to the rest of the body. Now, this big blue vessel in the center that we see right here, that's the coronary sinus. And that also is going to be tied in and dumped into the right atria. So the coronary sinus is returning the blood that the heart muscle itself has used. So all of these superficial vessels that you see on the outside of the heart wall are delivering fresh blood to the heart muscle, which is critical because if it doesn't get that, then it can't beat very well. And if it doesn't beat very well, we're toast. But once it extracts its oxygen, dumps in its carbon dioxide and any other waste products, then that used blood kind of merges into this coronary sinus that then returns that blood to the right atrium. So those are kind of the big, the great vessels that you need to know with the heart. All right, so we talked about our 4 valves already. You guys did good identifying those. In semester 4, we'll really practice listening for heart sounds. They are hard to hear. We don't have great quality stethoscopes. I'm going to see if we can't get some better ones ordered for you guys so that you'll have a better chance to hear it. But if you've ever listened for heart, you can hear this if you just put your head against somebody's chest. You can hear the lub dub. The lub dub are essentially the sound that the closure of the valves make. So the lub is the sound of the AV valves closing. And they close because when the ventricles start to contract, that pushes the blood upward, and that upward force of blood is what shuts the AV valves. As the pressure inside the ventricles generates enough force to push open the semilunar valves, whether it's the right or left side, then the blood is going to leave that chamber. And when the heart finishes contracting, it can't generate any more force. And so the blood that's in the pulmonary trunk and in the aorta starts to flow backwards. It's been pushed up, but it kind of lost its momentum because the heart can't squeeze any more force, and the blood starts backflowing, and that's what closes the semilunar valves, is that backflow. So both of these sounds are really related to actions of the ventricles. When the ventricles first start contracting, it closes the AV valves and generates this lub sound. And then when the ventricles essentially finish contracting, the backflow of blood is what shuts the semilunar valves and gives us the dub sound or dup sound. So that's what you're listening at. You guys familiar with all the structures in this image from lab last week? I see some yeses. I see some head noddings. I see some affirmatives, some yeah, maybe sort of kind of looks. I didn't see any no looks, so that's good. We're halfway there. So we've cut away basically the front wall of the heart to look at what's going on here. So you can see these different valves in particular. You can see the openings for the inferior vena cava coming right here. You have the opening for that coronary sinus that we talked about that allows the blood that the heart muscle has been using to get returned to the heart so we can get reoxygenated again. These white ones in the middle that look like parachutes are the valves. And so we've got the valve itself. So in this case, we're looking at our tricuspid or right AV valve. We've got all these little, I think of them as like guy wires. They're basically anchoring the valve to the muscle inside of the heart wall itself. And so inside the ventricle, the right and the left ventricle, we have these nipple-shaped projections that are called papillae. And that's kind of the term for a nipple-shaped projection is the papillae or papilla. And so they just look like little mounds, little nipples essentially. And that's the projection that lets the muscle in that area attach to these guy wires that then hold on to the valve itself. And so when that muscle contracts, it's going to pull down a little bit and create a little bit of tension on those wires, um, to so that when the overall heart wall contracts and pushes the blood out and forces that blood uphill, it doesn't let the valves reverse themselves. So the valves are facing this way. As the blood pushes up against them, it wants to push and seal things this way. And those little guy wires, the chordae tendineae, and their attachment to that papillary muscle is what prevents the valves from just being inverted. Think about like an umbrella that in a high windstorm reverses itself, and no longer functions very well as an umbrella. That's kind of what the chordae tendineae and the papillary muscles prevent. They prevent that umbrella from flipping inside out and losing the ability to be functional. And so when we get that, then if we had a failure of this and this valve was inverting itself and letting blood go from the ventricle back into the atria, then we're losing the ability to push that blood where we want it to go, which is out through that pulmonic valve, so it can go to the lungs. And so our ability to send blood to the lungs to get oxygenated becomes decreased if this valve fails. And it's pretty rare for it to like fail completely, but you'll get into situations where the valves, have a little bit of space in between them, or the valves get stiff and they don't really seal shut perfectly. And so then you have some leaking. So think about like if you've got weather stripping on a door or a window or something like that, or on your car door, if it doesn't seal perfectly and it's raining really hard, well, you might get a little bit of a drip, and that means that water is coming in where we don't want it to come in. And that's kind of when we start having valve issues, it lets blood flow the wrong direction. And when it goes backwards, it limits the function of the heart, but it also makes it more likely that the red blood cells in that chamber, as they hang around longer, they can start clumping together and forming little blood clots. And when they form little blood clots, then those blood clots can get pumped out into the body and clog up other vessels and cause problems like pulmonary emboli and strokes and things like that. So we definitely want those valves to work really well. Do you remember the term for the kind of, I don't know if Greg went over it with you guys, for the bulk of the interior wall inside the ventricles, kind of the appearance of that muscle that we have. It's not like a smooth, flat surface. It's kind of irregular, and a little bit wavy. It also reminds me of a Mexican food dish. So we have this carne, trabeculae carne. And so trabecular means just, it looks kind of like a lattice work. And we have that trabecular bone is another term for spongy bone. And so this kind of wavy looking appearance in there, that's the trabeculae carne. And I always just think of carne asada for some reason, because it kind of sounds like it. And maybe I like Mexican food. So anyways, that's the other muscular feature that you need to be aware of. That's kind of the whole wavy internal appearance. The actual distinct projections that attach onto the chordae tendineae are the papillary muscles. And we do see those in both the right and left ventricle. So I think this image does a pretty good job of showing you the difference in the wall thickness. So the myocardium is this pink kind of thicker tissue here on the right ventricle, and then compare it to how thick that muscle is on the left ventricle. That thicker left ventricle gives the left ventricle the ability to generate a lot more force and create higher blood pressures that can then deliver a higher amount of blood to the rest of the body. The right ventricle doesn't need to have a really thick wall because it's not having to fight gravity. Where it's pumping its blood is basically at the same level as where the heart is. It's just sending the blood sideways to the lungs, and then the blood's returning sideways. So you don't need to generate a ton of pressure. If we're trying to perfuse blood in somebody's body that's standing up, depending on how tall they are, you've got 5 or 6 feet of difference between the head and their feet. And it's a lot harder to manage blood pressure in a vertical situation where gravity is pulling that blood down. And the right ventricle, because it's only pumping blood at the same level of the body, doesn't need a lot of force. The other reason the right side doesn't need to generate a lot of force is The capillaries that surround the alveoli, we've got cajillions of them, and that's just an estimate. There might be a few more, less than a cajillion, but they're really small. And if we have too much force pumping blood into those capillaries, they're going to pop. And if they rupture, then that alveoli can no longer do its job of gas exchange. So we want to kind of keep the blood pressure going to the lungs at a pretty controlled level so that we don't damage those capillaries and limit the ability of the lungs to do its job. So this picture is kind of insightful. If you think about skeletal muscle, particularly muscles that you might be really familiar with, let's think about our quads or our hamstrings. Those are long muscles that go along the front and the back of our femur. They're arranged, the fibers more or less vertically. And so when they shorten, they just change the length of the muscle in one direction. Because the heart is trying to pull against itself. It can't just contract vertically. It can't just contract horizontally. It needs to contract in kind of all three dimensions. And it does that in kind of a twisting type of way. And so if you look at the way these arrows are drawn, think about how you wring out a wet towel, how you have to kind of like one hand rotates one way and the other hand rotates the other way. That's kind of what's going on with the heart. Now the heart, we have the atria contracting before the ventricles. So the atria are going to kind of contract with a little bit of a twist to kind of wring the blood out of the atria. And then the ventricles are going to contract with a little bit of a twist to kind of help wring the blood out of the ventricles. And that wringing motion helps generate a more effective emptying of the chamber so that we can pump more blood out with each beat. And when this picture is from the underside of the heart. And so you can kind of see how the fibers are arranged in this circular kind of pattern, and that gives it that ability to kind of twist and generate a more effective pump. When we look at patients that suffer things like a heart attack, the most common place where we see a lot of damage to the left ventricle is right down at the apex at the bottom. And so when the bottom part of the ventricle can't really do its squeezing and twisting correctly, then it really impacts how well that ventricle can pump. And when somebody has a heart attack, then it makes them really fatigue early because their heart just can't push very much blood with each beat. And so we lose the ability to generate a lot of blood flow when that left part of the vent, when that apex in particular loses effectiveness in pumping. If you have damage higher from a lack of blood flow higher up in the ventricle wall, it wouldn't be nearly as create nearly as much inefficiency as when we have damage at the bottom at the apex of the heart. All right, so I think we talked about everything pretty much on that right ventricle. The three return ports basically for all the blood in the body. Superior vena cava is basically where the blood from the head, arms is coming in from. Upper portion of the trunk. Inferior vena cava is pretty much everything else. All your digestive organs, all that stuff is coming through the inferior vena cava. All the leg muscles, all the reproductive organs, all that kind of stuff is returning its blood through that inferior vena cava. Coronary sinus is just where the blood that the heart has been using is coming back into the right atria. We have septums, and the septum is just a dividing line or a border, a section of tissue. And so we have an atrial septum and we have a ventricular septum. And usually they're termed interatrial or interventricular, just between the two atria or between the two ventricles. So those are running, if the heart was straight up and down, those would be basically running vertically. The heart is, like I say, tilted a little bit to the left, so they're kind of at an angle. You don't really need to know about the pectinate muscles, but you do need to know about that tricuspid valve. Right ventricle, again, the septum there, and then we have that trabeculae carne that makes me hungry. We talked about the papillary muscles, the chordae tendineae. We didn't talk about conus arteriosus. I have a heart. I had a heart model that I just decapitated, essentially. This isn't my favorite model. Let me shut off my sharing so you can see a little bit bigger. It's really big, but it's not my favorite model. I let Greg borrow the favorite one so he could use that for lab. So I've taken off the front. So we're looking at the right side of the heart coming in here. We can see the blue superior vena cava coming right here. We have this huge tricuspid valve. It looks like a molar or something in there. And so here's our right atria. Coming up here, I had to take off that front piece, but this is basically a circular entrance. And this conus arteriosa, the way that right ventricle is shaped, it's shaped so that when it contracts, it's going to direct all that blood through that conus arteriosus and push it past that pulmonic valve, which I just damaged that pulmonic valve, I think. It's a really big heart. It's not, I don't think, entirely anatomically correct either when I look at it. So let me go back to sharing. The sharing's nice. For some reason, it likes to move you guys to the other screen. And it takes away my chat. I lost two people again. There. Okay. All right, left atria. We've got those pulmonary veins returning both from the right side and the left side of the lungs coming in. And then we have that right AV valve, also known as the bicuspid valve, also known as the mitral valve. And here I've written that kind of tip to keep straight which side of the heart has the valve with three cusps and which side has two cusps. And then our left ventricle with the aortic semilunar valve at the top, sometimes just called the aortic valve, sometimes called the left semilunar valve. All right, we talked about that. Okay, let's talk about blood vessels. So we have lots of small blood vessels in the heart that penetrate, and just like when we look at the systemic circulation, we have arteries going to arterioles, going to capillaries. You don't need to worry about anything smaller than an artery as far as knowing for it. And really, you only need to know the things in bold on this particular slide. And there are some older names that you will still hear used, and I'll kind of mention those, but this book does use the more contemporary terminology for these vessels. So on this particular image, you can see how it's kind of shaded through this first section on this left coronary artery. That's because it's not right on the surface. It's tucked back behind this pulmonary trunk. And so that's why it's not as bright red as the rest. The part that's bright red is visible from the front of the heart itself. But this is just trying to show you the continuity of it. So if you look at where these two vessels are attached, they're coming off right at the very bottom of the aorta. So as the left ventricle contracts and pushes blood out past the aortic semilunar valve, it's going to come into this arch of the aorta. And these blood vessels that are splitting off get first dibs. The heart's kind of selfish that way. It's like, you know, if you want me to do all this work, you're going to have to feed me because I'm not doing this work without getting fed. And so we need the heart muscle to get great blood flow, because if it doesn't get good blood flow and can't beat vigorously when we need it to, we can't do a whole lot of work. The rest of our body's not going to work very well. So the left coronary artery is going to supply all the blood to that left ventricle in particular, and that's where it's really critical. Once it emerges out from underneath that pulmonary trunk, and this is the left atria, it's kind of popping out underneath the corner of that, then it splits. And when it splits, we have one branch that kind of wraps around more or less horizontally to go around to the backside of the left ventricle, and that's the circumflex artery. And then we have one big branch that comes down in the front in that interventricular sulcus, the anterior interventricular sulcus, and that's this anterior interventricular artery. The older and probably more well-known name for this artery is the left anterior descending, the LAD. So if you've heard that term, that's pretty common. Its nickname for the anterior interventricular artery is the widowmaker. It is called the widowmaker because if you get a significant blockage here, it will deprive the left ventricle of enough blood flow that it very likely could kill you. And since men have a higher incidence of death from sudden heart attacks than women, it's not the widower maker. I don't know. It's one of those sexist names probably. It is more common in men. So the widowmaker or LAD or anterior interventricular artery, that's the critical one for supplying the left ventricle with a whole lot of blood. Circumflex helps, but LAD is the bigger of the two. When we look at the other side, we've got the right coronary artery coming down, and it kind of stays named right coronary artery. It does have another branch that's going to split and kind of wrap around this tail that's kind of coming over here. That's called the right marginal artery. That's kind of the equivalent of the circumflex artery as it wraps around. So those are kind of the key ones to know. Goes from right coronary artery to the posterior interventricular artery. That's kind of more or less the equivalent of the anterior interventricular artery. And then the marginal is, like I say, continues on and helps get more the backside of the right ventricle, its blood flow. When you look at the pulmonary veins, you don't need to know any of these specific vein names other than the coronary sinus. So don't worry about that. We don't usually have issues with veins getting blocked. The issue that sometimes you'll run into with veins more commonly is that the valves fail. We don't really see that as much with coronary vessels as we do with peripheral vessels, particularly in the legs. So by far the bigger problem with circulation as it relates to the heart muscle is when we get blockages in one or more of these guys in this picture. And the more significant the blockage, if we're looking at 30% block versus 50% block versus 80% block, the more blockage, the more lack of blood flow there is, the more limitations the heart is going to have in beating rapidly or forcefully, because it's going to fatigue quicker and it can't get rid of its waste products quicker. And so the pH in the tissues will start to not be friendly for muscular contraction, and many times people will start getting chest pain, what's called angina, when they don't have good blood flow from these different arteries. We'll talk lots more about that in the coming semesters. All right. So as far as, let's talk about our tissue just a little bit, and then we'll take a quick break. I know this is a lot of cardiac stuff. So we've talked about muscle. We had smooth muscle, skeletal muscle, and cardiac muscle. And skeletal and cardiac have a lot of similarities. They both have the same basic organization of the sarcomere with the different zones and bands and all that stuff. The Z lines, the big difference between, some of the big differences between cardiac and skeletal are the branching aspect of cardiac muscle versus skeletal muscle doesn't branch. And the cardiac muscle needs to branch because it's trying to create this heart muscle that's going in all these different directions and has the ability to twist and all those things. That branching helps it do that. We don't have as many nuclei per cell or per sarcomere, I should say, or cell. I guess the cells aren't nearly as long when we think about comparing some of our longer skeletal muscles like biceps, triceps, quads, hamstrings. Cardiac muscle is involuntary, whereas skeletal is voluntary. And then the cardiac muscle has those intercalated discs. And we'll talk about those in just a bit when we talk about how the heart depolarizes to contract. Those intercalated discs are also known as gap junctions. They were some of the specific ways that cells are attached to one another that we talked about very early in the semester. And then they basically create a express lane for electrical signals to be carried through the muscle itself. They aren't necessarily nerve system pathways, but they help facilitate conduction of depolarization signals like a nerve does. And that's what I just talked about. I should have fast forwarded one slide ahead, but I didn't. All right, I think we'll take a break here. Give you guys a few minutes to catch a breather, get a drink of water, whatever. And then we'll come back and we'll kind of talk about how the heart conducts electrical signals and contracts. So I'll see you in, let's say 5 minutes. So like 9:02, something like that. Okay.
The heart's conduction system regulates the electrical impulses that make the heart beat. An impulse begins in a bundle of nerve tissue called the sinoatrial, or S. The heart's
All right, looks like 9:02. So we're gonna watch a quick little video. I think it's only about a minute or so that kind of just gives you a visual image of how that conduction happens kind of real time to help the heart muscle depolarize. Um, we don't have voluntary control over the heart. We do have a specific part of the heart muscle in the right atria called the sinoatrial node that's known as our pacemaking cells. And those cells work as pacemakers because they are not really able to hold a set resting membrane potential. They have a lot of leak channels that let ions kind of continuously escape. And so as soon as it fires, it basically starts drifting back towards the threshold that's going to make it fire again. And our vagus nerve, if you remember from our cranial nerves, is the nerve that kind of influences that heart rate. And if we have more sympathetic tone, then it makes it even easier for those, for that depolarization process to happen at a faster rate. If we have more parasympathetic tone, then it kind of inhibits things a little bit and makes it so that it delays how long of a time there is between depolarizations. It slows down the effectiveness of that leak channel and keeps the ions in balance a little bit better. So even when if you cut somebody's vagus nerve, they don't usually cut somebody's vagus nerve, but they've done animal studies where they cut on different mammal species. What they find is that the heart will often speed up pretty significantly. If we don't have any influence from the vagus nerve, then most people's heart beats at about 100 beats a minute. Normal heart rate is defined as between 60 and 100 beats a minute. That'll come up in some other classes. If your heart's slower than 60 beats a minute, it's considered bradycardia. If it's faster than 100 beats a minute, it's considered a tachycardia. But overall, we tend to have enough parasympathetic influence that most people are going to be kind of in that 60 to 80 range for their resting heart rates. So let's watch the little clip, and then we'll kind of review the individual components for this electrical conduction system.
Conduction system regulates the electrical impulses that make the heart beat. An impulse begins in a bundle of nerve tissue called the sinoatrial, or SA node. The impulse makes the atria contract, and blood empties into the ventricles. Next, the impulse travels to the atrioventricular, or AV node. It passes through the bundle of His, the bundle branches, and the Purkinje fibers. As the impulse reaches the ventricles, it triggers a contraction there, and the heart ejects blood.
All right, so if we look, before I change out of this little video, right up here is the SA node. So here's our right atria, kind of this whole big upper area. So that SA node is kind of in the upper right portion of that right atria. You can see these passageways that are kind of illuminated going through the tissues. And so these ones that are going around more the perimeter, these are the ones that would be formed by the gap junctions that are letting the depolarization signal from the right atria make its way over to the left atria, and also kind of spread that signal throughout the rest of the muscle mass in the atria. We want both atria to contract at essentially the same time, but we don't have a dedicated nerve itself like we do that travels through these septums. So that's kind of the first thing that happens. And there's a slight delay because we want to make sure that once this central line right here, this is actually part of the nerve itself. It's going to help depolarize the next major center, and that's the AV node. And so the AV node is kind of at the junction. It's really close to where all four chambers meet. So if you think about like four corners, that's kind of where that AV node is. Here's the intraventricular septum and the intraatrial septum. And then we'd have more of our coronary sulcus kind of crossing over this way. That AV node is still on the right side of the heart, and it is still, I think, right at the bottom or on the underside, kind of on the right atria, but that's kind of going to hold the signal up just a little bit. So it wants the atria to finish depolarizing and empty all the blood out of those top chambers before we pass the message on to the ventricles. If we get the ventricles and the atria firing at the same time, then the ventricles won't have as much blood in them as they would if we do the atria first and then the ventricles. So that AV node is really important in kind of setting up a little delay. From the AV node, we have this next section of nerve tissue that's called the bundle of His, H-I-S. It's not pronounced His, it's pronounced His like it has an extra S, but it doesn't. And so that's the passageway that's going to start sending the message to the ventricles. It's going to split. We're going to have a right bundle and a left bundle. And so these right and left bundles then split further into smaller fibers called Purkinje fibers. And those Purkinje fibers are the ones that are going to branch out and basically help innervate the heart, the ventricular muscle mass. And it's important with this nervous system conduction that we get depolarized, when we look at ventricular conduction, that we get the apex firing first. If for the atria, it makes more sense to have the top of the atria contract and kind of milk the blood downhill to the bottom of the atria. With the ventricles, it's just the opposite. We want the bottom of the ventricles contracting first to try and help push that blood up. And then as they tighten up, then the more superior layers of the ventricle continue to squeeze. And again, we're not just like my hands, I'm just doing this kind of flap, but we're getting this twisting or ringing motion in that chamber that's going to more fully empty those ventricles. So those are kind of the different components to the electrical conduction system. Again, our SA node starts it. These black lines represent basically the pathways for the gap junctions that help speed up and synchronize the depolarization of the atria. Then the AV node is going to fire to the bundle of His. Once the bundle of His splits, then we have a right bundle branch and a left bundle branch. And then those bundles have further branches that are the Purkinje fibers that then spread out. So that's kind of the things that you need to understand about those particular components. We'll get more into how the depolarization happens with physiology next semester, as far as like all the leaky channels and things like that. So you don't need to know a whole lot about that. You need to know structurally where they're located and what order the depolarization occurs in. These slides are kind of nice if visually, I'm not going to go through them because we've just kind of talked about it, but the way the green color changes kind of helps show how the different portions of the heart muscle are getting activated to contract to cause effective pumping. I should make my slide bigger. There we go. That's what I wanted. All right, so I mentioned EKG briefly. I mean, we'll talk about EKGs in physiology next semester. We'll talk about a little bit of them in pathology, and then we'll spend more time understanding different abnormalities about EKGs and what makes them normal and abnormal in semester 4 in therapeutic procedures 2. How many people are familiar with EKGs? Alyssa, you better raise your hand. There you go. Otherwise, I don't see a whole lot of hands going up. And Alyssa was kind of reluctant there. She's worried I was going to call her and ask her something probably. But as an EMT, I hope you're familiar with them somewhat. So let's look at the bottom picture, kind of big picture. The P wave, this first little bump, represents depolarization of the atria. And so you put surface electrodes on the person's chest typically, and when the heart muscle fires, those sensors in the electrodes can pick up that activity. We'll use the similar technology for skeletal muscles to do what's called an EMG, electromyography tracing, when we have people that have nervous system problems that cause their muscles to have a hard time firing and things like that. So that's all the technology is. It doesn't shock you at all. It's just picking up your own muscle activity. So we see this little bitty bump right there. That's the atria depolarizing. Then we have a little bit of a delay. This little pause is that pause that's created by the AV node slowing down the depolarization signal because it wants the atria to fully empty before we make the ventricles fire. And so the QRS complex is this bigger amplitude spike that's in the center. And it's got 3 letters, and the 3 letters represent changes in direction of the tracing. And so we have this solid line going along the bottom that's called our baseline or our isoelectric line. We see a little bit of electrical activity with the atria. Remember, there's not much muscle mass with the atria, so that's why we don't see a big amount of electrical activity, and that's what this vertical component represents on an EKG tracing. So this first little downward deflection is our Q wave, Then we get our R wave, and then we get our S wave coming back down. So all of this is ventricular depolarization. And kind of where we see the tip of the R wave, that's where the largest amount of the ventricular muscle mass is firing at once. We have ventricular muscle mass firing throughout the whole QRS complex, but it's kind of like this first part is what you're seeing at the apex at the bottom. And then as progressively more of the heart muscle gets activated, we see this big spike at the top. And then as some of the electrical activity starts to dissipate, then we get the downward deflection. From there, we have another little pause, and then the T wave represents repolarization of the ventricles. In most tracings that you'll see, the T wave is bigger than the P wave. Even though this is depolarization and this is repolarization, the fact that the ventricles have a lot more muscle mass is what makes this amount of electrical activity be greater than the atrial amount. So that's kind of what those represent. So the vertical amplitude represents how much electrical activity is occurring. The spacing between the individual tracings is more of the time component. And so this is just showing you 2 beats on this bottom strip. Usually when you see a strip like this, it represents 6 seconds of activity. And so if we're trying to count how many beats occurred in 6 seconds on this particular tracing, we usually just count the R waves because that represents the ventricular beat, and that's kind of the easiest point to go from. So we essentially have 1 heartbeat, 2 heartbeats, 3, 4, 5 heartbeats. So we didn't quite have enough time to fully repolarize the ventricles, but in this tracing, you're essentially seeing 5 beats in 6 seconds. So how fast is that person's heart beating? If we have 5 beats occurring in 6 seconds, there's math involved. I know it's Monday morning, but there's math involved. So if this is 6 seconds, how many of these tracings would fit in a minute? 10. Okay. So if we have 5 beats in 6 seconds, how many beats would that be in a minute? It would be 5 times 10. So roughly 50. Okay. So this tracing is roughly 50 beats a minute. So it's not that hard. I know nobody wants to ever be wrong. You probably all knew it. If you didn't, then you might need to work on your math a little bit. We'll go over the rates and stuff in another semester. All right, what do we got? 15 minutes left in the lecture. So we do have the SA node that is going to make the heartbeat on its own, and it does that regardless of whether we're getting sympathetic influence or parasympathetic influence. But we have talked about those autonomic nervous system components already. And so our sympathetic side, that's our fight or flight system. And so if you're going to fight or you're going to run away, you want your heart to be able to pump fast and hard. So it can pump a lot of blood to deliver a lot of blood to your muscles that need to fight or flee, to deliver a lot of blood to your eyes, your ears, everything, so you can be really aware of your environment. So sympathetic innervation is going to speed up both the force of contraction and the rate of contraction. Parasympathetic activity, our rest and digest, we don't need to pump a lot of blood to our muscles. We can just start sending blood to the organs that are digesting food and making urine and helping the reproductive cycle do its thing. So we can slow that heart rate down. And so parasympathetic influence, we're going to have a lower heart rate typically and a less forceful contraction. We're pumping a much smaller volume of blood with a lot of parasympathetic activity. That's really all. You don't need to worry about where all these different centers are and stuff like that. Just know broad effects of sympathetic activation on the heart and parasympathetic activation on the heart, and you're fine. All right, so cardiac cycle is one complete contraction going through depolarization of the atria, depolarization of the ventricles, and then resetting everything so that we can run the whole cycle again. So it includes both a contractile phase and a relaxation phase, and those terms relate specifically to the ventricles. It's not that the atria aren't important, but the ventricles are way, way more important. So contraction of the two ventricles together is systole. Relaxation is diastole. And those terms are also the terms that we use for measuring blood pressures. The lower number in a blood pressure is the pressure in between beats. That's the diastolic blood pressure. The higher number in a blood pressure is the systolic pressure. That's the pressure in the peripheral artery when the heart is pumping blood out and forcefully contracting. So those are important terms to know. If we have the term asystole, that's basically an absence of contraction. So that's flat line on your EKG. That's get out the paddles and shock that person kind of thing if we have asystole. All right, so when our heart contracts, we have 5 phases. We're going to get the SA node firing and those gap junctions helping to distribute that signal through the atrial tissue. The atria are going to contract. The ventricles are going to fill. If we're in an upright position, sitting or standing, blood returning to either the right or the left atria, as soon as it enters those atria, a lot of it's going to go ahead and flow down through the AV valves into the respective ventricles. Right before the ventricles are going to contract, we still want the atria to contract to more completely empty those. But the atria doesn't just hold blood until it fires. The valve opens downward. So the blood that's coming into the atria can go ahead and flow through that valve because it's already open when the heart's in a relaxed state. Once the ventricle, we get that signal passed through the AV node, through the bundle of His, through the bundle of branches, the Purkinje fibers, then the ventricles are going to start to contract. And when the ventricles first contract, we see what's called isovolumetric contraction. And so if we break that word down, iso means the same. So we have the same volume of blood in the chamber, even though the chamber is contracting. Essentially what's occurring is you're taking up the slack in the muscle tissue. Let's think of, if I have, actually, let me, hang on just a sec. All right, so I have my, let me make my screen bigger. I just thought of this, so hopefully it works. I think it will. So I have what's called a soft-sided water bottle, and I better burp it a little bit. Let some of that air out. All right, so my chamber is not completely full. So let's say I'm at rest, now it's got a leak too, so it's filling back up with air. So maybe this isn't working quite as well as I want. So if my left ventricle has blood in it, but it's not completely full, it might look like this, and you can see the water line in here. And so when the ventricle first starts contracting, it's going to push that fluid up, but nothing's going to come out the valve until I compress that chamber enough. So when we have isovolumetric contraction, the muscle's contracting, but the volume of blood inside that chamber stays the same. It's not until I push hard enough that we're actually going to see some water escape. I'm making a mess. I'm sacrificing my office floor and getting my pants wet. Well, shorts wet because I'm not wearing pants. Anyways, that's kind of the idea. If the chamber's super full, because the heart's beating really hard and the atria is pumping a lot of blood in that chamber too, then I'm not going to have a shorter period of isovolumetric contraction, but we're not going to actually get blood moving out of that ventricle until we compress that ventricle small enough that the volume of blood in there now is forced out the semilunar valve. Hopefully I didn't get water on my computer anywhere. I don't think I did. It's an old computer. I could use my new one, I guess. All right, I got to get your names back here. I lost my people. In my chat. Okay. So once the ventricles get to that point where we create enough internal pressure to push blood out past the semilunar valves, then we're going to get ventricular ejection. Blood is going to leave either the right ventricle or the left ventricle and go into the vessel that it needs to go to. Once the ventricles contract fully and start to relax, then we're going to see the ventricle space open back up, but we're not really going to have more blood coming into that ventricle until it relaxes enough that the atria can then start dumping their blood back into it. So we need to get everything relaxing again, let the atria relax. Now the blood that starts returning into the atria can then start flowing back through the AV valves and start filling the ventricles again, and then we'll repeat that process. So those are kind of our 5 steps. And it goes on 24/7, on and on and on and on as we go. So those are our phases. Blood flow through the heart. Did you guys talk about this with Greg in lab? Okay, so be familiar with that order. Make sure you know kind of where it comes in, which valve it goes through when, and how it goes to the lungs first and then comes back to the left side before being pumped out to the rest of the body. So that's important to understand. As we get older, like our skeletal muscle, our heart muscle gets stiffer and weaker and doesn't work as well. And so when it gets stiffer, then it makes it harder for those chambers to accept a lot of blood. And if it can't stretch and accept a lot of blood, then it starts out with a lesser ability to push a lot of blood out with each beat. So we want to, if we use that muscle on a regular basis, just like if we use our skeletal muscle on a regular basis, it will maintain more pliability and maintain a better ability to expand as we age and still generate high stroke volumes, which can then increase the pumping of the heart. And if we challenge the heart on a regular basis by making it beat vigorously, frequently, then it stays stronger and it's able to keep working pretty well. We do see distinct differences in how the heart responds to resistance training versus aerobic training. And we'll talk more about this in probably therapeutic exercise in semester 3. If you think about doing like max lifts, if anybody's ever done max lift, you're doing your max squat, you're doing your max bench press, whatever, you generate a lot of internal pressure in your vessels because you're like pushing super hard and tensing up and doing this big Valsalva maneuver that restricts blood flow. And your heart, as it's trying to pump blood out while you're like straining with that heavy weight, as your muscles are contracting, they're generating external pressure on all the arteries and capillaries, and that makes it harder for blood to escape. And it means that the heart, in order to push blood through those arteries, has to generate higher forces. And so when the heart has to generate really high forces, it needs to get a really thick muscular wall to generate high force. Think about somebody that can lift a lot of weight. They have big, thick muscles that are capable of generating a lot of force. So we see thickening of the heart wall a lot of times with resistance training. If the heart wall thickens, but the chamber doesn't stretch and get bigger, then we basically shrink the internal space in the heart. And it can make it harder to pump a lot of blood with each beat. You can pump the blood out with a lot of force and generate a high pressure, but not necessarily a high volume of blood. Somebody that does a lot of aerobic activity tends to have bigger chambers because they're pumping such a large volume of blood that their chambers become a little bit bigger. And as long as the thick heart muscle thickens enough that it can still effectively compress those chambers, then you can pump pretty forcefully and generate a pretty high amount of force, but you can pump a lot bigger volume of blood too. And so that's generally thought to be a healthier way to have the heart become conditioned, is to have the ability to pump large volumes of blood as opposed to being able to generate lots of pressure with the blood that you're pumping. When the heart muscle gets thicker and thicker and thicker, sometimes you can have problems with it having a hard time depolarizing in a synchronous fashion. There's so much muscle tissue to depolarize that it's hard to make it all fire at once. And there have been cases of people that have really thick heart muscles going into weird electrical abnormalities because their heart the signals kind of get crossed because you're trying to depolarize it at the same time. Other parts of the ventricle are trying to repolarize, and it can create some issues there. So we do want to use the heart. I'm not saying don't do heavy weightlifting, but I'm saying it's not the best type of exercise for your heart. Aerobic exercise is the best part as far as keeping the chambers and the strength of the heart kind of in balance with one another. The other big benefit of aerobic exercise relative to strength training exercise for the heart is the stimulus that it creates to the blood vessels in the heart muscle itself to create better perfusion to the heart muscle. Because aerobic activity demands the heart to work continuously at a high rate for a long time, we need to be able to deliver a lot of blood and remove a lot of the waste products. And aerobic training does that more effectively. It helps the body grow more blood vessels into the heart muscle, so that it can just, if you do have a problem, you have more alternative pathways for blood to flow. And we don't see that same response with resistance training typically. Might make you swole, but it doesn't really help your heart as much. Makes you look better at the beach in the summer, and it helps you. Strength training helps you immensely in most of our society's popular ball and field sports. So to be a good football player, baseball player, it's definitely more important to have the ability to generate lots of force than it is to have lots of endurance. When we look at sports that are more continuous in nature, something like soccer, compared to football or baseball and baseball in particular, you got so many breaks. You don't really need to have very good endurance. You get a break after every single pitch. So you don't really need to go continuously. All right, it is 9:30. Let's take our little break before lab. And with lab, I'm gonna start going through the vessels. We'll kind of start at the heart and work our way out on the arterial side, and then we'll kind of look at the venous side and kind of start distally and work our way back in. And so take about 10 minutes. It's 9:30, so be back at 9:40. You want to ask me your question, Crystal, or do you want to make it private?
No, that works. So my question is, I know they said they'd give everybody an hour between the Zoom lectures to get to the labs, but what about for the ones that live over an hour away? It takes me like an hour and a half to get from my house into the campus.
Let me talk to everybody else about it. I've been out of town when they were kind of had that discussion. I know kind of that's what we did last year. And there definitely were a couple people. Most people made it. I did have, one or two people that lived in like Ogden that would take the train down and they would just watch the Zooms on the train. But if that's not an option for you and you're having to drive,
We don't have a train.
yeah, then
But my question is if it's an interactive lecture and I'm trying to drive.
Yeah, it's not ideal from a safety standpoint or for your ability to pay close attention to it. So I definitely understand that concern. I can let people know about that and we can see if we can bump it out a little bit. And I don't think that would be impossible to do by any means. It's just a matter of shifting things around a little bit and seeing what we can do with that. So I'll message the rest of the department and let you know.
Okay.
And see if we can shift that.
Yeah, because I was like, I don't know, I won't be able to make it in an hour. So
yeah, I get it. I mean, we've had people from your area and one, I'm trying to think.
I
They've
think
done okay,
Crystal
but I
lives
know
about
that's
the
a big,
same distance too.
sure. Yeah, if you're farther down one of the small roads and you got, and then if you're coming in during a busy traffic time, um, then that can cause complications getting through town and all that kind of stuff too. So yeah, I'll ask about it and see what we can do and let everybody know that that's a concern. I know Alyssa had mentioned she was probably moving closer in, but if that's not an option and you can't move, then and you can't change how long it takes, then we'll have to figure something out for you.
Okay. Yeah, no, I can't move and
Yeah, I think, it's, we were told that we were going to be able to have everything on campus, and then I think corporate decided, I haven't talked to them, but I guess because of the Delta variant and the more increased spread that we're seeing, they decided to kind of walk it back a little bit and not make everything on in person.
yeah.
We got this email that we're presenting it like, okay, here's our big changes for the fall. You're gonna be able to come on site for on-campus labs, and we're like, we've been doing that for the last 3 semesters. That's not really a change for us. So we were, I mean, I get it because we are seeing a big increase in cases across the country. So I get why they rolled it back, but it's definitely disappointing and it creates a scheduling hassle for us too. So
Yeah. And then I've got to figure it out because I've got kids too.
Sure.
So
yeah. Well, I will. Yeah, as soon as we finish with class, I'll message the rest of the group and let them know your concerns and see what we can adjust.
okay. Alrighty, thank you.
You bet. All right. So I have pulled up a website from Visible Body, which did I talk to you guys about that at all before I went on vacation? It's an app that we're considering using starting next semester. Some other parts of Unitech College System have been using another interactive tool called something like BioDigital. I haven't used that one before, but this one is pretty cool, and I'm hoping we can get it integrated for next semester for you guys to be able to use for kinesiology as well, because it does have really nice visual images and has different apps that you can do for different body systems, and I think it would be a good adjunctive tool for kinesiology, for pathology next semester, for physiology as well. I wish we would have had it for this semester for you guys, because I think it would have been helpful, especially the fact that we had to do everything virtually. So I'm going to try and use it these next few weeks that we've got left for this class to kind of show some things and give you guys a taste of kind of what it has in it. So it's nice in that I spent the last 5 minutes or so hiding a lot of the other body structures that were covering the circulatory system, so that we can visualize those things a little bit better. So it gives you that ability to kind of take things away and put things back in place, so you can kind of see the interrelationship between all these different structures. It gives me the ability to basically move the image different ways. You can see things at different angles. I can actually like tilt it forwards. You can see it from the top, or tilt it kind of backwards. You can see it from the underside. So we're going to use this today to try and kind of help with these main blood vessels that you're going to need to know for next week's lab quiz, and then for the final and lab practical and all that good stuff too. So here we've got the heart, and you're looking at it pretty straight on. So we're going to trace the arterial side away from the body and kind of look at all these things coming through the upper chest and get you to understand kind of what these subclavian branches and carotid branches and how those all tie together. We'll look a little bit at the circulation in the skull for the brain. We'll look a little bit at the digestive organ circulation, and then we'll look at the extremities as well. Those are kind of the big focus areas for the quiz. You don't need to know every single vessel in the body. Don't worry about that. But kind of the bigger ones are the ones that we're going to try and help you gain an understanding of where they're located. So we're looking at the front of the heart. Here we've got our pulmonary trunk coming up right here and splitting. I took away the pulmonary vessels coming out for this particular portion. So we're going to look really just at the left side of the heart. So we've got our arch of the aorta coming up here. And when I click on it, it's going to tell me up here, hopefully you guys can see this, that's the arch of the aorta. And so as a learning tool for you guys, if you pull this up, then you can basically kind of click through. If you're not sure of what something is, you just click on it and it kind of tells you what it is. So that's pretty cool, I think. I'm going to rotate this just a little bit so we can see those three vessels that come off. If you remember when we looked at that picture of the arch of the aorta. So if I click on this one right there, that's our brachiocephalic trunk. And again, this is coming off the right side of the heart. And so it's basically coming right up here, and it's going to split. And you can, let me remove this, and you can kind of see that split a little bit. I'm going to take that out of the way too. And take that out of the way. So right here where it splits, this branch that goes and stays vertical, that's going to be our right common carotid artery. So we've got the arch of the aorta, we have the brachiocephalic trunk is this one continuous section. It's going to split into the right common carotid artery And then the side, the part that splits off laterally, that is our right subclavian. And so I've taken away the collarbones, but the collarbones are the clavicles. And so subclavian just tells you in the name, it runs underneath the clavicle. And so and these are pretty symmetrical in the body. So most of these vessels, you're going to have them on both the right and the left side. We do have a difference with this. There is no brachiocephalic trunk on the left side. The left side, when we look at those vessels, the left common carotid is this center one. Whoops, I need to go a little higher on it. Right there. So that's our left common carotid. And then this one that's more posterior, the last of those branches coming off, that's our left subclavian. And it highlights on this app the boundaries, essentially. And so a lot of these vessels are just like a road that changes names when it passes certain landmarks or certain intersections. It's the same continuous blood vessel, the primary one. It just changes names when it crosses different regions in the body. And especially when we get down into the extremity, I don't think you need to spend a ton of time memorizing stuff. Most of these body regions we've already gone over in like the surface anatomy chart, or when we talked about the terms for the different extremities. So you're going to see those same terms: brachial, femoral, popliteal, radial, ulnar, tibial. So you can usually guess the name of the vessel just based on where it is in the body and what other bony structures are near it. So hopefully that won't prove horribly difficult for you. So aorta, brachiocephalic trunk, right common carotid, right subclavian. This second vessel in the center coming off the arch is the left common carotid, and then we have the left subclavian. So those are kind of those central ones that are branching directly off of the aorta. When we start getting out to the arm, I'll go ahead and do these arm ones since I'm kind of, well, no, take it back. Let me do the head ones. Let me slide down. Oops. Bring his head into view a little bit. And we will tip him backwards a little. So now he's kind of like semi-reclined here. So here we've got those carotids coming up. And when we look at circulation to the brain, the carotid arteries are kind of some of the big ones. We have inside the vertebrae, we have vertebral arteries. And so those are also really important ones too. Let me swivel him sideways a little bit and make him just a little bit bigger. All right, so right here, this is all common carotid, and we're looking at the right side. As it comes up, we're going to have a split. And so it's called the common carotid because that's where all of the carotid blood flow is going. Where it splits, that's where we have two distinct branches. And so the one that is more anterior right there is our external carotid. The one that is more posterior is our internal carotid. And it kind of, the internal carotid one is going to dive in deeper. The external is going to stay out a little bit more laterally. And that's where those names come from. So those are kind of the main ones that you need to know going from the heart up to the base of the head. We'll look at some other images that go over the specific cranial circulation in just a second. But you would have those same things on this other side. I still have the jugular in place. I'll probably leave that so that way we can go through those as well. But hiding behind this jugular vein, so the jugular vein and the carotid artery are basically in parallel with each other. So this right here is our jugular vein, the blue one in the front. But this would be our left common carotid coming up. And then right here is our split. And so again, we would have a left external carotid and a left internal carotid right in there. So that's kind of what we're looking at with those images there. Let's look at, let me back that out just a touch, and we'll talk about these central vein ones kind of closest to us. Again, with the jugular, we also have an internal and an external jugular vein, kind of like we had with the carotids. I don't think I asked you any of that. I think the quiz itself you don't need to be able to recognize the difference of the internal and the externals for the carotids and the jugulars. You would need to know the difference between the carotid and the jugular, but not necessarily their sub-branches for that particular one. So if we look at our veins, right here, we've got our superior vena cava coming in. And so that's collecting the blood from the left and right subclavian veins. And so that's what we're looking at here. Let me bring him so he's a little bit more horizontal. So that's our subclavian vein running in parallel with the subclavian artery. Almost all of these vein and artery names are the same, whether it's the arterial system or the venous system. We do have some differences like carotid versus jugular, but most of them in the limbs, it's going to have the exact same name. Just, is it blue? Is it red? So coming off of or returning from the skull, going into the subclavian, then we're going to have our internal jugular vein right there. I think it must merge, and it's really both the internal and external. What is this little guy? That's the vertebral, so never mind. Let's swivel it around just a touch. And then this one here, that must be our external. Yeah. So our external jugular is significantly more lateral than the internal. So that's a little bit different than the orientation that we had with the carotids, where the carotids, we have that common carotid and then it splits much higher up. You can see this is our subclavian vein. And so the external jugular dumps into subclavian vein rather than merging into the other portion of the jugular vein. So those are kind of our more central ones. Let me go down just a little bit and we'll talk, whoops, that'd be up, not down. I hope I knew how to work this computer better. All right, let me move this out of the way. That's our linea alba. We don't need that. We also don't need the xiphoid process in the picture. So here is all our inferior vena cava coming in the bottom side. And then here is that arch of the aorta. And let me see if I can make the heart disappear. That might take a while. Trying to make it so you can see the backside of the aorta, but there's too many individual structures in the heart. There it goes. So here's the arch of the aorta. It wraps, goes up above that pulmonary trunk and the right and left branches of the pulmonary arteries, and then it comes down. And so once it starts, we have what's called the ascending aorta, then we have the arch, basically the top, and then we have the descending aorta. We don't see the diaphragm in here, but essentially the diaphragm is following along the same arc as kind of these lower ribs that we see. And so once that descending aorta crosses through the diaphragm, then it changes name to the abdominal aorta. And so if I click on it down here, oops, there's too many other vessels in there. Now we're down to the descending or abdominal aorta, more specifically. And there's a ton of vessels in the way there. So I'm going to go to a different set of images and we'll look at some of those more precisely. So let's talk about the Circle of Willis. Circle of Willis is kind of the old name. Now they're just calling it like the intercerebral circle or something like that. I can't remember what the new contemporary terminology is. I learned it as the Circle of Willis because whoever Willis was, they named it after. And so when we're looking at this, this is kind of looking at the underneath the skull. You can see the brainstem coming in here. So we've got our pons medulla kind of structured there. Over here laterally, these are going to be our jugulars, or excuse me, our carotids. So if I click on that, there's our internal carotid. Again, the external carotid I don't think is visible in this particular image. And the term Circle of Willis refers to the fact that there is basically a ring of blood vessels coming into the bottom side of our brain that gives the brain the ability to help reroute blood. So it kind of gives us the ability to detour and have some built-in alternative pathways for blood flow to continue. And this is really important if in the case of somebody that gets a blockage in one of those vessels. If I get a blockage like right here, let's say, in this particular section of artery, then the blood could potentially still get to the area that that artery branches off to by coming around from the other side, because it is this circular system. And so it's kind of a fail-safe to ensure that we're getting at least some blood flow, even if one of the arteries going to a particular section of the brain is impaired or obstructed, like you would see with somebody that has a stroke or somebody that threw a clot up to one of those vessels and clogged it up. So that circle of Willis is super important. You don't need to know any of the specific vessels for this quiz coming up. When you get into neuroanatomy, you'll probably revisit a lot of these vessels, and they've identified when a patient has a stroke that affects this particular vessel, these are the likely problems that you're going to see. They're going to lose sensation in this area. They're going to lose motor control in this area. They're going to have a hard time communicating between these lobes, and they're going to have a hard time with speech or whatever the case might be. So they have kind of mapped that out. And so when somebody has a stroke and they have their diagnostic imaging, their CT scan and their MRIs and stuff like that, they'll try and identify where the blockage was. And that helps us as therapists understand the likely deficits that we're going to see. So it is kind of important stuff to understand. The bigger vessels that we see coming up in addition to these carotids are going to be the vertebral arteries. And so we have a right and a left vertebral artery, and these are the arteries that are traveling in between those transverse foramen on the vertebrae in the cervical spine. So if you remember the cervical spine, we have those lateral projections, the transverse processes, and they have little holes in the middle of them. And those little holes are so that artery has a rim of bone protecting it in that area. And so that's the other kind of primary vessels that deliver blood to the brain, the carotids and the vertebrals. The two vertebral arteries merge and form what's called the basilar artery right through here. And so we're going to have a left and a right basilar artery. And then the actual circle of Willis is kind of this collection right here. And then it has branches that go, laterally as well as anteriorly and posteriorly. But that common circle in the center is what gives us the ability to kind of get at least partial blood flow to areas of the brain that might have bigger areas of occlusion that are limiting blood flow. But those would be vertebral artery and the carotid arteries. Beyond that, you don't need to know more than that for this particular, maybe basilar, but any of the other ones, don't worry about them for now. If we let's look at the trunk just a little bit. Trying to decide which one of these I want to show. Take away the colon, small intestine, okay, let's take away the liver. We haven't gone over these organs, but we will very soon. Kind of wish we would have talked about the organs first, but that's not how it's organized, and I'm not that creative to reorganize it. All right, and there's our stomach. Took it away. All right, so we've got this network of blood vessels that are up here that are basically delivering blood to the upper organs just below our diaphragm. And so we have what's called the celiac artery. And the celiac artery is going to be the one that has branches that then deliver blood to the liver, to the stomach, and to the spleen. And those are kind of the three uppermost organs in our abdominal cavity. So liver, stomach, spleen all have a shared central circulatory thing called the celiac artery. And so when I click right there, that's showing actually one of the branches. So the celiac's probably right there. So the celiac trunk comes off of the abdominal aorta. That's what's running behind all of this stuff. And then it's going to branch out and form this kind of section of other arteries. The other arteries are named based on where they're going. So coming off of the celiac artery, if we look over here, we have the hepatic artery. And so that term hepatic refers to the liver. If we look over on the, here's our spleen way over here. And so if I click on the one for the spleen that branches off the celiac trunk, that's our splenic artery. So that's pretty easy to keep straight. And then hidden back behind here, hopefully, is going to be our gastric. Yes. So our gastric, if you hear that term gastric, that refers to the stomach. So a gastric artery is going to deliver blood to the stomach, a splenic artery to the spleen, a hepatic artery to the liver. And so all three of those are coming off of the celiac artery, or this, excuse me, the celiac trunk. Our next set of organs that comes down below, I kind of disappeared already, so we could see these blood vessels. But the next set, we've got the superior mesenteric artery, and we have an inferior mesenteric artery. The superior mesenteric artery is going to kind of be the one that's in charge of the next lower set of abdominal organs. So the small intestine, almost all of its blood flow comes through the superior mesenteric artery. The large intestine, it's kind of split. Some of the large intestine is pretty high up. Before I made it go away and hit it, it basically runs up all the way. It creates kind of like a box. So we have an ascending colon, we have a transverse colon, we have a descending colon. Kind of the upper portions of all that gets blood flow from the superior mesenteric artery, the lower portions of those, and then the sigmoid colon, which actually leads to our way out, the rectum and the anus, that's going to be more lower mesenteric artery. This is the pancreas right here, this kind of tannish colored organ, and that's also going to be really close to the small intestine, and that gets its blood through the superior mesenteric artery. We've got the kidneys back behind it. Those are not supplied by that same vessel. They have their own circulatory system. They're kind of more behind the peritoneum, and so their artery supply is different than the digestive organs artery supply is. So those are kind of the three big ones. All of these small little loops that you see down here are branches coming off of the superior, the inferior mesenteric artery. I think mostly the superior is kind of this one that's more kind of oriented on the right side, and the inferior mesenteric artery is more the one that tends to be a little bit more on the left side. If I click on it, it's marginal. I'll pull up a document in just a second that kind of gives you a list of all these, the ones that you specifically need to know. And the images that you have in your slideshows for this lab give you a good idea of which ones you need to know and which ones are in bold. But I like this visual with this tool, pretty cool. So those are kind of the main ones that you need to know for the gut. Celiac, superior mesenteric, inferior mesenteric. If you have a general understanding of which abdominal organs are given blood flow to by those vessels, then that would be the key other thing to kind of know. When we look at the venous side of things, it's pretty much the same terms. I think I have questions on the artery side more than the vein side with these particular ones. Let's go back to my limbs. I go up to the arm. It's kind of a slow motion joystick, apparently. I need like some dramatic music as I'm like moving my way up the trunk. Like a Space Odyssey, 2001. I don't know. All right, let me take away some bones so we can see some stuff here. All right, take away, I think that's probably good. So we have, I'll take away the sternum too, just because it's cool. And this one I like because you can take all that connective tissue away at once. Then it leaves these little fragments of connective tissue that's kind of annoying that I have to click on so many times to make it go away. All right, so here is our subclavian vein coming over. Again, these veins are returning blood to the heart. So let's talk about the names of the veins. Once we get, if I click on it there, so there's subclavian. If we go a little bit more lateral from subclavian, then we start getting into that armpit area. And so it changes name to axillary, just like that region of the body is the axilla. Okay, we've got that vessel there. Let me scroll down a little bit. Here we've got our humerus, also known as the brachium. And so as we move through there, then we've got the basilic artery, because it wants to change names and be a little confusing. Over here, we've got the cephalic, or excuse me, vein. These are both veins. And so these are ones that are a little different in name. But if you look at your own arm, you can usually see those veins coming up. So the cephalic one is going to be the lateral one. The basilic one is going to be the medial one. That's kind of where those are. And again, the blood is returning up these. If we go a little lower down the arm, we're going to get into this junction where they meet and become common. And so that cephalic vein, and now we have, here's our basilic vein, and our basilic vein cuts across. And this is usually the vessel that you can see right in front of your elbow in that antecubital fossa. And so that changes and has this little connection called the median cubital vein. And I don't even think you need to know that much detail. You do need to know basilic and cephalic and axillary. And then when we get down into the forearm, the only ones you really need to know would be the radial and the ulnar. So the cephalic is going to travel all the way down, and then it's going to split into a little branch of radial. And then over here, you're going to have these ulnar branches coming off of the basilic as well. So the vein, I would say the veins are a little bit harder, just in that you do have those additional names. When we look at, let me go back up. You don't need to know anything in the hand or the wrist. You can stop at the radials and ulnar levels. Let me back up just a touch. And then we'll get, wow, that's not backing up. That's backing up. All right, let's start back up at the top for the arteries. I'm going to make this vein disappear. Okay, so we've got our arch of our aorta coming up. We've got coming off of the right, we're going to have our subclavian artery coming off of there. And then that artery is going to change name to the axillary artery, just like we had with the veins. Here we're going to get a difference. We're going to have that vessel is the brachial. So with the veins, we had the basilar and the cephalic veins, but in the arterial system, we go into the brachial. And then if we go down further, we're still brachial all the way down to that antecubital fossa. So that's the blood vessel that we want to put our stethoscope on when you take somebody's blood pressure, is that brachial artery. It shows up in blue right now because I've got it highlighted, but it's not. It's not the blue one. It's going to be the red one right there. So once we start getting down here and it crosses over and becomes below the antecubital fossa, then it's going to change names. And so it becomes the radial, and it continues on. So it's basically coming across your forearm this way, and then it becomes radial. So it goes towards the thumb. Anytime you hear radial, be thinking thumb side of the forearm. You're going to have that additional split. Let me go down a little lower and turn this fella just a touch. And over here, if I can click on it, should be our ulnar. And so that's our ulnar artery. And the radial artery is the one that you're usually going to take somebody's pulse at. And so if you look right by the lateral part of the wrist, if you feel the lateral styloid process in your wrist, that's where you're trying to find that radial artery to take somebody's pulse. Blood pressure, we're typically trying to find the brachial artery. And so those are two pulse points that we really need to be able to locate and palpate and find in order to take these measurements accurately. So see if you can find your radial artery. So right by your thumb side of your wrist, again, when you're trying to palpate a pulse, don't push hard. You just want to, if you push hard, you kind of interfere with your own ability to sense things. Plus you can basically pinch blood flow off and occlude that artery, and then you won't feel the blood flowing past your fingers. And essentially that's what you're feeling. Every time that heart contracts, it pushes a wave of blood through those arteries, and you get this big surge of blood. And that's what you're feeling under your fingertips if you're feeling that at your radial artery. Was everybody able to find theirs? Okay. You can find the ulnar artery on the other side, kind of in the same spot. It's deeper, so it is a little bit harder to feel. And that's why the radial is usually the preferred one. If you're having a hard time finding it, sometimes if you have the person extend their wrist back a little bit, it'll push that artery more towards the surface and make it a little bit easier to see. Now see if you can find your brachial artery. So come up, and again, try and kind of get right in that antecubital fossa in your elbow and see if you can feel that brachial artery. And usually you want to use 2 fingers. It's kind of the typical way, and a very light pressure. That's where you want to find it. And when you're taking blood pressure, it's super important that you put the stethoscope head right on top of that artery. If you're not on top of it, you still might hear things, but you're not going to hear it as soon as you should, and you're not going to be able to hear it for as long as you should. So you're likely to underestimate the top pressure, and you're going to overestimate the bottom pressure. So you're going to kind of shrink the range of the blood pressure value if you don't hear that really, really clearly. Think about trying to hear something. Let's say somebody knocks on your door. If you're in the front room in your house, that person can knock at a pretty light volume and you're still able to hear it. When you're taking somebody's blood pressure, usually when we pump the cuff up, and everybody's had their blood pressure taken. When you pump the cuff up high enough, you're going to cut off blood flow to the arm. And as you open the valve and the pressure in the cuff starts to go down, when the pressure in the cuff matches the pressure in the artery during systole, when the ventricle is contracting, then blood is going to start flowing through that artery and you'll start hearing a noise. When those values are pretty equal and just a little bit of blood is flowing, that noise is really faint. And if you're not right on top of the artery, you're not going to hear it. And so if somebody's knocking at your front door really loud, really softly, if you're in the front room, you might hear it. But if you're in your back bedroom, you're not going to hear it. And they might have to knock louder. And that's kind of what happens. As the pressure in the cuff goes down, more blood starts flowing through that artery, and the sound that you hear becomes progressively louder. And so you have to train your ears to be able to pick up that faint noise first. And if you're not in the right spot on that brachial artery, you're going to miss that faint noise. And when the pressure starts going down and the pressure becomes more even in the vessel and the cuff, then you quit hearing the noise. Once the pressure in the cuff is less than the pressure in the artery, you don't really hear it anymore. You need to have some occlusion to create the turbulence that gives us the noise. And if we're not in the right spot with that stethoscope head, we're going to miss the bottom end. You're going to think that the sound disappears at 90 when really it should have disappeared at 80. And so we can get inaccurate measurements. So I'll harp on that when we get into procedures 1, really being careful to find that location. Was everybody able to find the brachial artery? Okay. You can find the brachial artery also up higher. It runs in the inside edge of your humerus. And so you can usually feel it kind of right in between biceps and triceps, right along the bone there. And so that's another location that sometimes you can find it on with people. All right, let's talk about the legs a little bit to kind of review this. Let me back up just a touch on my image. So let me disappear my linea alba. And I think that's probably good. So we've got our descending aorta coming down. It's going to split to go to the right side of the legs and the left side of the legs. And so if we click on it right here, it's still considered the descending aorta. Once it splits, what is this bone right here called?
The ilium.
That is the ilium. And so the artery that is in that region is our iliac artery. And so we have an internal and an external iliac artery. Trying to think if I can even, I think probably over here is going to be we've got like, it's kind of a TMI with this picture. There's so many vessels in it, it's kind of hard to discriminate. But the external one is the easier one to identify, and that's kind of the more primary one that's going to be continuing on as the primary source of blood flow. The internal iliac splits off of here somewhere, but I can't really, there's too much other stuff in the way for me to pick it out and click on it. So you do need to know right and left external iliac artery coming in through here. And then as we go more distal and start going further down the leg, now we're crossing in front of the hip right here. And so that vessel is going to change name and become the femoral artery. So we go from the abdominal aortic artery to the right and left external iliac arteries to the right and left femoral arteries. And that's going to continue on down the leg. And you can see that it kind of disappears. We're looking at the front of the body right here. So let me turn him around. He got bigger. He moved closer to me when I turned him around. And we'll back it up. And then we'll scroll down a little bit. So now we're looking at the back side of the knees. And so you can see here where the light blue is, that's where the name changed femoral artery kind of ends. This region behind the back of our knees is the popliteal fossa. And so this is our popliteal artery, is what its name is going to be. So that's not too bad, hopefully, to keep straight. If we continue further down the leg, we see another split. So here's our popliteal artery. We see this branch going anteriorly. Here's our interosseous membrane. And so this is our fibula over here. And so the branch of the popliteal artery that moves towards the front of the leg right here is going to be our anterior tibial artery. The part that's going to stay on the back is going to be our posterior tibial artery. So the anterior one there, posterior one here, and here's our tibia. So the posterior tibial artery runs right behind the back side of the tibia. So it's kind of underneath those deeper lower leg muscles. Things like flexor hallucis longus, posterior tibialis, flexor digitorum, those are kind of the deeper muscles that attach on the back side of that tibia and that fibula. You do see another branch coming off over here, and this is going to be it's going to go right behind the fibula, and so that's our fibular artery right there. So we have two branches to the tibia, an anterior and a posterior, and then we just have the one from the fibula, but they're all branching off of that same artery that started up at the split from the abdominal aorta. External iliac to femoral to popliteal. Once we get into that popliteal space, the first split is the anterior tibial coming off, and then it continues on. We have that secondary split, and that's where we're going to go to fibular versus posterior tibial. On the quiz, or on the written exam, when you're looking at the images, if it asked you to identify a particular vessel name in the extremity, pay attention to what bone it is right next to, pay attention to what region that is in the body. It's almost always going to be one of those two things. It's either going to be the region, like the popliteal or the iliac, or it's going to be the bone, like the tibial, anterior tibial, posterior tibial. Pay attention to the image. Is it showing you the front of the leg? Then the vessel's more likely to be the anterior branch. If it's showing you the back of the leg, the vessel's more likely to be the posterior branch. You don't need to know any vessels below the foot and the ankle. So you just need the ones that we just talked about: anterior tibial, posterior tibial, fibular, popliteal, femoral, and then external iliac. And those are kind of the main ones. If we look at the venous side of things, let's go down to the bottom here. And we've got our saphenous veins. Let me swivel him around. Make him a little bit bigger. Whoa, maybe not quite that big. So on a lot of people, you're going to be able to see the great saphenous vein. It's a really superficial vein. It does run all the way down your leg. Let me back up a little bit here and bring him back down to me. Bring him back down to earth. So that saphenous vein, you can see this vessel that's kind of out in the perimeter, and we've taken away all the muscle, but all of this vessel right here is basically the great saphenous vein. It goes all the way down the inside part of our leg and crosses over down the inside part of our ankle. So that's the easiest superficial vein to recognize. The ones that are deeper are almost all on the back side, and they're going to be really similar to the artery names that we just talked about. Make them a little bigger. And so if we look at the veins over here, we've got our posterior tibial. Over here, we're going to have our great saphenous vein, so that whole collection there. On the other side, you're going to get the fibular, and then if we come around to the front, you're going to get this should probably be the anterior. Oops, clicked on nothing. It's still saphenous. I think the tibial ones are probably too deep to see, and I don't know that you need to know them, to be honest with you. Let's back that up a touch. As we come behind the back of the knee, here's our fibular one coming in. Here's our two branches of our tibial one merging. So there's our fibular. There's our posterior tibial. They're going to merge and become the popliteal vein. And then as we go further up into the body and we move past that space behind the back of the knee, running in parallel with that femoral artery, we've got the femoral vein. So the names, just for the most part, the arteries and veins are very, very similar. And I don't think it'll take a lot to keep straight which ones are which when we look at those particular vessels. Let me pull up, I'll have you guys do some more activity stuff for all these vessels tomorrow in lab, but let me pull up this set of slides, and this is one. This should be available in the week 12 module, so if you just go into the lab activities folder in Canvas, you should be able to pull these particular slides up. So these are the ones that are labeled, and so really just pay attention to the vessel names that are highlighted, either highlighted like this in yellow or bolded. And those are the ones that you're responsible for. The ones that are not bigger, I'm not worried that you know the little small ones. There's so many of them, there's way too many to keep straight, and it's not really that critical for our field. But the big ones are. And so this kind of talks you through all the big ones. So pretty much anything in bold as you go through on these slides, those are the ones that you're going to want to know. You don't need to know the specific location where the name changes. I think as long as you know those body regions, you're going to be okay in figuring out the name just through kind of common sense and prior knowledge. So again, on this slide, this one will show you, here's our descending aorta. There's our diaphragm. And so these little branches coming off that are cut, this first one is the celiac. The second one is the superior mesenteric. This bottom one is the inferior mesenteric. So those are the big branches coming off of that descending aorta. They're going to feed the abdominal organs. I don't think this set of slides has a good picture of those real specific ones as far as your brain vessels. We talked about the carotids, we talked about the vertebral, and we talked about the subclavian. So I think everything bolded here we kind of went over. And again, those are the main ones that you need to know. I'll look at the quiz again to see if you need to know these. I mentioned knowing the vertebral and the basilar. If you do in fact need to know these two carotid ones for the quiz, I'll let you know tomorrow. But this is a good helpful set of slides to look at. The other thing that's helpful, we have a couple, a study guide. And so this study guide also lists the vessels that you need to know. So this would be, use this document in combination with that set of slides. And that's probably going to be the best way to help yourself kind of get started preparing for next week's lab quiz. Any vessel questions on the written exams will come from the illustration images from the textbook. The ones from the quiz will, again, like it has been all semester, be from that cadaver dissection tool. So make sure you're looking at the circulatory vessel images from that cadaver dissection tool to help yourself get ready for the final lab quiz next week. But that's kind of the big list of the specific vessels that you need to know. And again, some of these I would say, like these digital ones and palmar arch ones, you don't need to know those. If you see a blood vessel going to the kidney, that's a renal artery. If you see a blood vessel going to the reproductive organs, well, that's a gonadal artery. Those are kind of common sense type ones. As long as you know what the name refers to, you should be able to just kind of follow it along and see which organ it's going to figure it out with that one. So I think that's probably good on our vessels for today. So let's talk about finals week and see what you guys want to do with that. So my original syllabus had us ending everything the week of August 16th, 17th or something. Let me pull up the calendar here. Yeah, so 17th was scheduled to be our last day for all that. My grades won't be due till later. We are ending our other, the second semester or the second year students will end that week. But I don't think it should be a problem if we want to push the final to Monday. Do you guys also want the lab final to be pushed out? Or do you want to do the lab final the preceding week and then just have the final, the written final to worry about for that following, for the 23rd? What are some thoughts on that?
I'd rather them both pushed back.
Have both pushed back?
I was gonna say the opposite. I'd rather have the lab on the same time.
And nobody else is offering up an opinion. They don't want to get on the wrong side of Lisa or Missy. Oh, I like them both. I don't know who I should make mad at me.
I would rather take the lab the earlier week.
I would too, just because some of us have other classes other than this one, and they're all on the same day.
They're all on Monday,
The Tuesday, the
the 24th,
17th.
on the 17th.
Mm-hmm. So if we could split them up, because I know that we have our PTA intro final that day as well, so that
Yeah.
we're not written lab practical intro final.
Now, for those that are taking like the English and the psych and the algebra or whatever else you're having to take, when are those finals scheduled? The 23rd, 24th kind of thing?
I think by the 25th,
yeah.
but it's online. You can do it early or.
Okay, so
I
those
think-
have more flexibility with it. I mean, I'm okay with pushing both of them to Monday if you want, but and you are studying a lot of the same information. It's just really different images between the two different, different sources that you're having to look at. Both of those exams have a number of questions on them that are recycled from previous exams. So it is going to be beneficial to look back through your old exams and your old quizzes. If you don't have access to the old, like if you can't go back and look through what you did on Lab Quiz 3 or whatever, let me know and I'll see if there's something I can change in the settings to give you that ability. But both of those, it is helpful to look through all those prior exams that we've taken with all this stuff. Um, any other strong opinions one way or the other? It sounds like we've got a few extra people that would rather have the lab the preceding week. So we want to go with that. We're saying no, we're saying yes. How about
So if we do the lab on the 17th still,
Mhm,
could we start it maybe a little bit earlier so we have
definitely, yeah.
okay.
Yeah, we could, we probably would end up doing is just we could spend some of the lecture time just doing some review for both the lab and the lecture potentially, and then definitely give you plenty of time for the lab quiz. And that way, if you need a mental breather before you have to go into your intro exam, you'd have a little bit more of a breather. You won't be finishing up the lab quiz and then rushing right into your intro exam. So yeah, we could definitely bump that up a little bit. And then Monday, the 23rd, all we would do is just come in and have the written exam. And I'll give you, I could combine the lecture and the lab times into that and give you as much time as you need to take that one also. I haven't really had prior students take necessarily a whole lot more time than an hour and a half that is scheduled just for the lecture time. But if it bleeds over into the lab time on Monday, then that would be fine too, because we'd already be done with the lab quiz and not having to worry about cramming that in there. Okay, so let's plan on that. We'll keep the lab quiz on the Tuesday, the 17th. I'll go ahead and change the date and the times and stuff for the written exam for the final to the 23rd. Give you that weekend to kind of regroup and have a better chance to focus on that. And then you can pick and choose sounds like with your other online classes when you're gonna knock those out. If you want to do those on the Wednesday, Thursday, Friday of the interim, and then have kind of your whole weekend to finish studying up for the lecture written exam, then that'll give you that chance to do that. Okay.
And the study guide isn't open until Sunday the 8th, correct?
For what, for the fall?
The study guide
Or the
for,
study guide?
yeah, or could it be opened earlier?
The way that I read it, let me pull that up on mine. I thought it was locked out until you did the course evaluation or something like that. Yeah, the way on my end, I don't know, can you guys see my screen still on that? So we've got this end of course survey, and I guess that doesn't unlock until the 8th, is that right? And so you can't see the study guide until then because you can't take the survey until then. So that's kind of a problem. Yeah, I'll probably, I'll see if I can post it someplace else. I don't want to mess with their settings that they've created. I didn't lock it out that way. That's something new, and they didn't even tell us they were going to do that. But yeah, you can't even look at any of that stuff. So I'll put those in a different module or something, and so they're visible somewhere else. So I'll do that once we finish class, so you can start seeing both the lab one and the written one for that final. Yeah. Any other concerns with that? Honestly, I think the written exam, the preceding study guides, all those study guides for small tests 1, 2, 3, 4, 5, it's mostly just kind of a combination of those. And so most of the other preceding study guides should kind of point you in the right direction, but it is nice to know exactly how many questions are coming from which areas and that kind of stuff. So yeah, I'll get those, put those in a separate module for you and let you know when I do that. Yep, great.
Yeah, so just to clarify, Craig, you said like the written exams will be good to go back and study all those different tests, 1, 2, 3, all that, and
Yep.
the past exams.
Mm-hmm.
And with the lab that's coming up, there's going to just be a whole bunch of different pictures. Would those images and pictures be from the, what's that interactive kind of,
Yeah.
is it going to be more of
Yeah,
Okay.
just like the lab quizzes have been from the anatomy and physiology revealed to dissection kind of pictures. That's where the
Dissection pictures.
lab
Okay.
ones will be from those images. The written ones will be just text questions, as well as, you know, any images from on the written exam will be the illustration images from your textbook, the ones that are typically shown in the PowerPoint slides and things like that.
Okay.
All right. That'll help me a little bit too. I'll be able to maybe spread out a little bit. We have a lot of chapters to come, looking into, like, we've got to finish going through like lymphatic system, digestive system, reproductive system, respiratory system, and we don't have that many more sessions left. So by not trying to fit in the lecture exam that Tuesday, the 17th, we'll be able to maybe space that out just a little bit. You don't need to know a ton of detail on most of those body systems to come. They're ones that, with the exception of the pulmonary side of things, we can't do a ton about necessarily. So I don't spend as much time on them. And I don't expect you to have as much depth of knowledge with any of those two. As far as like the digestive organs, you're going to need to know where they are and need to know their function, kind of what their primary thing they do for us in the body, but you don't need to know a lot of nitty gritty detail on those things. And then same thing with reproductive. There's a lot that we could talk about in reproductive, and we will revisit some of those things as they relate to therapy when we look at dealing with things like incontinence and pelvic health and strengthening the pelvic floor. So there definitely are things that we need to know about in those areas. And it's not that they're not important, but there's not as much that we can do about stuff going on in the digestive system. So yeah, let me work on getting those modules visible for you. Any other last minute questions? Any questions on the heart, since that's the quiz that you'll have tomorrow?
The quiz tomorrow, is it mainly just like the structures of the heart, I would assume?
Yeah, so knowing the chambers, knowing the different the walls, knowing the different things that help, the different valve names, the things like the papillary muscle and the chordae tendineae on the valves. That's kind of the main things. And yeah, I don't even think the great vessels are on it. I don't even think any of the cardiac vessels are on it. I'll double check, but I think all the blood vessel stuff's on the next one. So I think it's more just the structural parts. You would probably need to know like the coronary sulcus and the interventricular sulcus, the anterior and the posterior and things like that. But it's mostly about knowing the chambers, the valves, and then the things that help the valves kind of hold themselves together, as far as the chordae tendineae and the papillary muscles and that stuff. Okay. All right. So we'll move into chapter 3. We'll knock that at chapter 23 tomorrow. We might start moving into 24 depending on how much time we have, but if not, we'll just worry about 23, and then we'll have the lab quiz, and we'll do some more hands-on or group activities for the vessels to kind of help you get ready for next week's lab quiz too. But otherwise, I will see you guys tomorrow.